I want 10 jumps. Ready, go. 1, 2, 3, 4, 5, 6, 7, 8.
The active cycle of breathing techniques can be introduced as a game from the age of about 2 years. Huffing, or forced expirations, are one of 3 breathing techniques which make up the active cycle.
Okay, now let's see if we can make the chicks jump. I think we can fly.
Up to the ceiling.
Up to the ceiling. Okay, do you remember? Tube in your mouth. Go huff off that. Good. And try again. Don't move forwards. I'm watching. Good. And again.
The purpose of the active cycle of breathing techniques is to help clear bronchial secretions as quickly and easily as possible, and it can be used as an airway clearance technique in both surgical and medical patients. It comprises the techniques of breathing control, or normal breathing, thoracic expansion exercises, or deep breathing exercises, and the forced expiration technique, which is 1 or 2 huffs combined with periods of breathing control.
Relax your shoulders and arms and breathe gently under my fingers. In, gently out. In, gently out.
Breathing control, or breathing using the lower chest, is an essential part of the active cycle. It allows a pause for a rest and prevents any increase in airflow obstruction.
Gently out. Good. Now I'd like you to try a huff by taking a small breath in and gently squeezing the air out, like this. Small breath in and squeezing the air out. Try one yourself.
Okay.
Good. And rest. Can you make one just a little more gentle than that? Breath in again and gently squeeze the air out. And rest. After 1 or 2 huffs, it's important to return to the normal, gentle breathing. To move the secretions from the smaller, more distant airways, it's necessary to continue the huff for a little longer. Try one that's a little bit longer. Good, and rest. When you can feel the secretions up here in the upper, larger airways, the way to clear them is by taking a big breath in and either using a huff or a cough. A deep breath in and huff. Try one yourself. Good, and rest. When clearing secretions from the upper airways, it's not necessary to continue the huff for as long. Well done.
During a forced expiratory manoeuvre, huff or cough, points known as equal pressure points develop within the airways. They occur where the pressure within the airways is equal to the surrounding pressure, or pleural pressure. The position of these points is dependent on lung volume. Downstream of the equal pressure points, that is, towards the mouth, there is dynamic collapse and compression of the airways. With decreasing lung volume, the points move towards the more peripheral airways, and this explains why huffing to a low lung volume is necessary to clear the more peripheral secretions. In addition, there's an oscillatory movement within the airways, and it is these mechanisms which assist the mobilization and clearance of secretions.
When teaching the huff, there are several points to watch for. The huff shouldn't just be a noise in the back of the throat. By keeping the mouth and glottis open and contracting the abdominal muscles, it is very easy to produce an effective huff. If someone is having difficulty it is often helpful to try blowing down a tube, for example, a peak flow mouthpiece, or blowing a tissue, or cotton wool ball. The blow very easily converts into an effective huff. The huff should never be violent. The length of the huff and force of contraction can be altered to maximize the clearance of secretions. Now I'd like you to try a deep breath, breathing in beneath my hand. The deep breathing helps to loosen the mucus in the airways. So trying a deep breath in, filling up beneath my hand, and gently out. And again.
By increasing lung volume, air can move behind secretions and assist in mobilizing them. This can be demonstrated in a model of collateral ventilation. With an increase in lung volume, the resistance to airflow via the collateral channels is reduced. This may be via the pores of cone, or through the bronchiole-alveolar channels, or at the interbronchiolar connections.
Try and relax your shoulders a little more, and a deep breath in, good, gently out. Deep breath in, and gently out. And again, deep breath in, gently out. And rest. After 3 or 4 deep breaths, it's important to return to the breathing control.
If thoracic expansion exercises are continued for too long, the patient may become dizzy with hyperventilation and unnecessarily tired. It's often helpful to begin teaching the active cycle in the sitting position and then use the positions most productive and comfortable for the individual patient. The cycle always begins with breathing control.
And now, as you try 3 or 4 deep breaths, I'll do some chest clapping. So deep breath in and gently out. Good. And again. Gently out. One more. And rest. This time, during the breathing out part of the deep breathing exercises, I'll do some chest shaking. Deep breath in and gently out. And again, deep breath in, gently out, and rest. Small breath in, squeeze the air out, and rest. And another huff, this time a deep breath in, and try and clear it. Fine. Well done. And rest. It's important to continue the cycle of breathing control, thoracic expansion exercises and huffing until the airways are as clear as possible. Try some more deep breaths. Deep breath in, gently out.
It may be helpful to determine the end point of treatment as the moment when the huff remains dry-sounding and non-productive during 2 consecutive cycles.
Good, and rest.
The active cycle is flexible. There's no fixed pattern. It varies according to the individual patient. Sandra has bronchiectasis and considerable airflow obstruction. Her program varies. When she has an exacerbation, she needs longer and more frequent periods of breathing control between the more active parts of the cycle. A cycle may include breathing control, thoracic expansion with clapping, breathing control, more thoracic expansion with chest shaking, breathing control, and the forced expiration technique. The active cycle of breathing techniques is also used in surgical patients with excess bronchial secretions, but chest clapping and shaking are not normally included.
I'm going to take a big deep breath in, hold it, and out. Deep breath in, and out. Big breath. Hold it, hold it, hold it, and out. One more big breath in, and out. Okay, and just do some breathing control, nice and relaxed.
As the intrathoracic pressures generated by huffing are less than those generated by coughing, huffing is better tolerated in the post-operative patient.
Okay, and we're just going to sit forward and try a huff. Okay, so small breath in and a huff out. Okay, and sit back. Nice and relaxed.
The emphasis in the surgical patient in whom airway clearance techniques are indicated is on effective huffing and breathing control. Patients will benefit by using a 3-second hold with the thoracic expansion exercises, but walking to increase tidal volume may be an effective alternative.
Okay, you have a seat. Do some quiet breathing. Sit forward, we'll do a huff. And sit back. Okay. I'm sorry about school. You can come and sit down. Do you want to take your pyjama top off, please?
Okay.
We do some of those breathing exercises. Okay, thank you. It's over here. Right. Right, Robert, let's just do some relaxed breathing. Just let your tummy come up into my hand. That's good. Right, let's try some huffing. Where's your tube? Right, see if you can make this cotton wool ball move. Good. Where'd it go? I've got it. And again, small breath in, just huff out. Good.
If a child has a condition with chronic sputum production, the parents can assist physiotherapy using the active cycle of breathing techniques from about the age of 2 years.
Emma. Breathe in. 4 deep breaths. Come on. Emma, big breath in. We have those 4 breaths, Emma. 1. Remember, they're silent, aren't they? We don't hear you breathing. Alright, let's have a rest. Let's just do some tummy breathing. Alright, then try 4 big breaths again, and Mum's going to do some clapping. Big breath. 1, 2, 3. Alright, let's just go back to tummy breathing. Hello, Alex. Can you show us what treatment you've been doing at home? Come and sit up on here.
Alex has primary ciliary dyskinesia and has had problems keeping his middle lobe clear. Owing to his dextrocardia, his middle lobe is on his left side.
Okay. Right, what do you do?
Well, first I do sleeping first whilst I check myself.
Yeah. Well done. Then what do you do?
Then I stop and do 3 smaller breaths.
Okay, show me how. That's lovely.
Then I do a half.
Okay, just stop. Try and do your huff a little less hard and a little bit longer. Have another go. Well done. Have you got a postural drainage frame like this at home?
No, but I'm hoping to get one soon.
Are you?
Children from about the age of 8 or 9 can usually learn to do some of their own treatment.
Okay. Well done.
Alex has no signs of airflow obstruction, but in patients with acute asthma or emphysema, the pauses for breathing control should be longer, possibly 20 to 30 seconds. A useful and comfortable position in which to assist clearance of secretions in breathless patients is high side lying. Positioning can also be used to encourage breathing control.
Now take some deep breaths in. Deep breath in and just let the air out quietly.
Some patients are too breathless to pause for a hold at the end of inspiration, but if they can manage it, it may be a useful technique to help loosen secretions.
Back to breathing control again. And then when you're ready, try a huff. Right. Try breathing control again. Get your breath back, let your head relax and your shoulder drop. If you try and make the huff a little shorter and use your breathing control straight away, you can cut down on the exhaustive bouts of coughing. Okay, because coughing can make, vigorous coughing like that can make you more wheezy. So when you're ready, try another huff, a bit smoother, and use your breathing control to avoid the cough. Good. Breathing control again.
Andrew has cystic fibrosis, and when it is inconvenient to use gravity-assisted positions, the active cycle of breathing techniques is effective in sitting. The sitting position is also used if gravity-assisted positions are contraindicated and when secretions are minimal. Andrew's cycle includes breathing control, thoracic expansion exercises with chest shaking, breathing control, and the forced expiration technique. Andrew finds self-compression useful with huffing. Exercise is an important adjunct to any treatment regimen.
Well done, and move to the chair.
Huffing with breathing control during an exercise session may be useful.
And rest, listen forward, breathing control. And try a huff. And again. And rest. One more. Sandra, how much physiotherapy do you think you can realistically fit in at home?
Well, I usually try and do twice a day.
Good. Do you find it keeps you clear?
Yes, normally it does, yeah.
What positions do you use?
Well, in the morning I usually do my uppers.
Yes.
And then when I come home from work about 6 o'clock, I do either mids or bases.
Good. And your next doctor's appointment's in about 4 weeks' time?
Yeah, 1 month.
Splendid. We'll see you again then to check your techniques and reassess your programme.
Okay.
Good.
Sandra normally manages her own treatment at home, but at regular intervals she comes to the physiotherapy department for reassessment and review of her techniques. Some patients feel that clapping helps them to mobilise secretions. Provided that it is not exhausting or causing an increase in hypoxemia, the decision is left to the patient. Sandra has a productive chest and usually needs to spend a minimum of 10 minutes in any one productive position. She usually uses 2 positions during a treatment at home. Patients who require several gravity-assisted positions may, for example, use 2 positions at one session and 2 at another. It's usually more effective if a maximum of 2 positions are used during any one treatment session, rather than trying to do several positions for a shorter period of time. The huffing technique was used in New Zealand many years ago by Bernice Thompson, and it was this technique that was used in the studies at the Royal Brompton Hospital in the late 1970s. These studies showed that using the active cycle of breathing techniques, more sputum was cleared in a shorter period of time than using the more passive form of physiotherapy. More recent studies have shown that the active cycle is not further improved by adjuncts such as positive expiratory pressure, PEP, the oscillating PEP of the flutter, or mechanical percussion. Clinical studies have shown that the active cycle can improve lung function and does not increase or cause hypoxemia. It is easy to teach and easy to learn. The active cycle is a comfortable method of treatment. It should never be uncomfortable or exhausting. It can be done in any position, and it's more important to be in a comfortable position than in a theoretically correct position. It can be used for the very young or the elderly, for the sick patient or for the fit patient. It can be used either with an assistant or independently. Most patients appreciate being able to control the management of their own treatment. Continually adapting the techniques in response to assessment of the individual is central to the effectiveness of the active cycle of breathing techniques.